Welcome everyone, and thank you for watching this presentation. We're going to spend the next hour going over a few of my secrets to Invisalign patient selection, and hopefully that will open some eyes and shed some light on how I'm looking into the mouths and figuring out who I'd like to get started, and who represents a smooth and trouble-free case, and how I'm going to do that. So, let's get past the disclaimer here. The statements, views and opinions expressed in this program and related course materials are those of the speaker. That would be me. Align Technology Incorporated may not endorse such statements, views or opinions. Attendees are responsible for legal and regulatory compliance of any marketing and referral programs. Here are the 4 secrets to patient selections. I'm going to cover these in pretty good detail as we go through. The first one that's popping up is not a secret, so it does not have the number 1 in front of it. Stable, healthy, periodontal structures should be given and are known. Everyone doing any type of Invisalign therapy should have a stable and healthy periodontal structure. That should not be a secret. That should be common knowledge. It's much safer and healthier to move teeth when the gum and the bone are healthy and stable, and when there is no bleeding and there is very shallow pocketing. Now, as far as the 4 secrets to patient selection go, I'd like to start with the maxillary arch. And my big secret number 1 is that the maxillary arch is the key to success. So my favourite photograph is the photograph of the upper arch, and we're going to spend a lot of time in the next hour looking at the patient's photos, and we're really going to focus in on the upper arch. I'm going to teach you all the things that I'm looking for in that arch, in that picture, to let me know that this is going to be an excellent case for Invisalign to handle, and not only to treat, but basically produce a perfect outcome so that everyone is happy on every level and the patient has a beautiful smile, and also a perfect occlusion and healthy periodontal structures that they can go forward with through the decades and enjoy their own teeth for the rest of their lives. Secret number 2 is what I like to call diagnosing and treating the cause. So we're going to review some of the causes of crowding. It's nice to identify what was the cause of the crowding because it's a whole lot smoother and kinder for the patients and yourselves if you're actually treating the cause versus treating the symptoms. And those are 2 different worlds. When we're treating the symptom of something, we get a different path and a different outcome, as opposed to when we treat the cause of something. So we're going to review a little bit of diagnosing and treating the cause of crowding. Secret number 3 is transverse measurement. It's an orthodontic measurement. I didn't make it up. The transverse measurement is obviously a dimension in the world of orthodontics, and I'm going to teach you today what the transverse measurement is in the mouth, and I will also show you how I employ that to help me as a diagnostic tool, and then also as a treatment tool, so that I can use it to help better develop my expansion. So I can produce proper arch form and proper arch width for my patients. Now, the 4th secret is the buccolingual inclination. And the buccolingual inclination is a handful to say, but it's not that difficult to understand. I have slides coming up shortly in photographic view to give you an idea of what exactly I mean by buccolingual inclination. So we're going to cover that. So now you know my 4 secrets. Maxillary arch is the key, diagnose and treat the cause, what is the transverse measurement going to be, and how will it affect my case, and what about the buccolingual inclination? Alright, let's move forward. Secret number 1. Let's focus on the maxillary arch for a minute. So for me it really determines how the entire case is going to run. What is the maxillary arch doing? Okay, it's not about the amount of crowding. I spend very little time focusing on the lower anterior teeth. I know for GPs that's quite common. Right away we look into the mouth. We look at the anterior teeth. We look at those lower teeth all jumbled up. Maybe the upper teeth a little bit too, but we get swept away with how much crowding we might see, and we might even get a little bit nervous or a little bit uptight about what kind of crowding the front teeth have. And the more we stare at the lower front teeth and their crowding, the more difficult it's going to be to treat the case. It's really not about the amount of crowding in the mouth, okay? I never measure what the crowding is. I will not look at overlap and say, there is 2 millimeters here and 1 millimeter here and 1 millimeter and a half there, and come up with a number of 6 or 7 or 8 or 10 millimeters of crowding. I'm really not interested in the amount of crowding in the mouth. It's not about the lower anterior teeth. Part of the maxillary arch being the key, as one of my secrets, is that it has nothing to do with the lower anterior teeth right now. If we're going to unravel some serious crowding, and we're looking at the patients to see whether or not they are good Invisalign candidates, the big key is the maxillary arch determines how and where expansion can take place, which allows that lower crowding to go away. When the maxillary arch can be developed, the lower arch will follow it. The lower anterior teeth will have a place to unravel into. So it's a sequence of events that gets us to those lower anterior teeth, and not necessarily just getting in there and doing IPR on the anterior teeth and trying to spin them into place. That's not my favorite technique. What I'd like to do is look at the whole mouth, look at all 28 teeth, look at the shape and the size and the width of the arch forms, because as soon as I determine that the maxillary arch could benefit from expansion, and it would be appropriate to do so, now I know the lower posterior segment has to follow that expansion. And once the upper expands and the lower follows it, all of a sudden there is room and space to unravel that anterior crowding that we see almost immediately when we look in the mouth. It's not about the age of the patient. It really does not have any bearing on the case, whether the patient is 20, 30, 60, 80. It has no relationship to what is going on with the patient. I treat all ages up to the age of 81. That's my so-called record for age in the office, and the 81-year-old we treated was one of the happiest patients that we've done Invisalign on. So age is not so much of a factor as to whether or not I'll start an Invisalign case. If you have that stable, healthy periodontal structure to work with, and the patient is interested and willing to do Invisalign, then certainly it will provide a benefit to them. So now let's take a look at what it is about. It's all about the shape and the width of the maxillary arch. And what I mean by shape and width of the maxillary arch is, do we have proper arch form and proper arch width? And that's where we're headed with this next segment. So now that we know it's all about the shape and the width of the maxillary arch, that means it's all about the posterior teeth. So, secret number 1. The maxillary arch is the key. As soon as the focus is on the maxillary arch, I'm more interested in where the posterior teeth are. Because as soon as we determine where those posterior teeth are in the maxillary arch, we know if we have the proper shape and width of that arch to accommodate the lower teeth. And if we don't, that's wonderful news. So part of what we are determining when we unravel these secrets to Invisalign case selection is the focus is on the maxillary arch to determine if we have proper form and width. And if we don't, then it's amazing how much crowding we can unravel with very little to no IPR. And if there's one thing that you could do to your life to simplify your Invisalign treatment, we know it would be to eliminate the IPR altogether. So we're going to take a look at how this helps us do that. So now that we understand what we're going to do with the maxillary arch as to being a key determinant of where we can go with expanding, we should look at what causes crowding. So we get an understanding of where that crowding came from. Now this leads us into my secret number 2. Secret number 2 is to diagnose and treat the cause. There are things that cause that crowding, and there are things that are the symptoms of crowding. And we like to distinguish them because, as I mentioned before, treating the cause gives you a different path and a different outcome than treating the symptoms. So let's go through the causes of crowding real quick. The number 1 cause of crowding is improper arch form. Improper arch form is a cause of crowding. Now, what does that mean? We know what it means. We see it every day in the office. The V-shaped arch, the omega-shaped arch, the square or box-shaped arch. And then there are combinations of the above. We know patients who look just like this, and we see them all day, all week and all year long, and they walk in with an improper arch form. And when you have a V-shaped arch, or an omega-shaped arch, or a square or box-shaped arch, or any of those combinations, you're going to have an amount of crowding in there. And that's what I mean with improper arch form. These are all bad arch forms. Well, what does good arch form look like? Would be nice to define that. The arch form takes its shape from the second molar all the way around to the opposite second molar. And if we want to establish what good arch form looks like, it means connecting the dots. Go from the buccal cusps of your second molar to your first molar through your premolars, and then start hitting the incisal edges of all those anterior teeth and come right back around to the other side. Now, this right here would be an excellent example of what good arch form looks like. So if we can trace these buccal cusps through the incisal edges and work our way all the way round, we've got great arch form. Now, when the patient walks in with a V-shaped arch, or an omega-shaped arch, or that square or box-shaped arch, it does not look like this. And the goal is to create this. Change it. So what can take a V-shaped arch to an arch like this? Well, that would be Invisalign. That's the whole point of providing Invisalign, because it's very capable of developing proper arch form. So I'm very excited when I see patients walk in with a V-shaped or omega-shaped or square-shaped arch form, because I know I can convert that into a beautiful arch like this. And the way I remember this? I was taught a long time ago, if we were thinking about the architectural world, a V-shaped arch is a Gothic arch. If you look at cathedrals and architecture in Europe, you see a V-shaped arch and identify it as a Gothic arch form. Well, we're looking to convert the Gothic arch form to this nice dome. And this nice dome, if you've seen pictures of Italy, you would know that this is a Roman arch. A Roman arch is a round arch form. And so when it pertains to the mouth, the maxillary and the mandibular arch forms should be a Roman arch. That's an acceptable and ideal arch form in the mouth. And we know that a V-shape is not. So the goal is to take that Gothic arch that the patient walked in with and convert it into a Roman arch, so you would have established a proper arch form. As the leading cause of crowding in proper arch form, when you take an arch form and convert it into a proper arch form, you are unraveling the crowding. So we're going to be able to treat some very nice severe amounts of crowding with little to no IPR in relatively short amounts of time. So we're looking for this kind of arch form, and we're going to get into this case later on and show you where it all started. These are the final photos. Number 2. So we know the first cause of crowding is improper arch form. The second cause of crowding is improper arch width. Now, what does that mean? Well, let's take a look at a little bit of research, and this was done over a period of about 5 decades. But there is a very simple piece of information for you here to understand what kind of arch width is an acceptable range. Uncrowded adults have a 35 to 39 mm transverse measurement. Now, the transverse measurement is the shortest distance between upper first molars measured at the gum line. I'm going to show you a photograph of how I measure that in a moment, but getting back to that research. Uncrowded adults. That means that the population of people aged 15 and over who were studied that did not require any type of orthodontic treatment were shown to have a width across the upper arch of 35 to 39 mm. The range accounts for tooth size and gender predominantly. So, obviously, female would be on the lighter side of the numbers, and male might be on the heavier side of the numbers. Tooth size. If you have smaller teeth, you're going to be on the lighter side of the numbers. If you have larger teeth, you're going to be on the larger side of those numbers. So that means that an uncrowded adult, meaning an adult that has no need for orthodontic care, whose teeth are perfectly placed, and who has a nice arch form, will have an arch width in the range of 35 to 39 mm. So the transverse measurement is my secret number 3. I measure that on every single patient because I like to know what kind of arch width I have to start with. and that gives me an idea of where I can go to finish. So the transverse measurement is a distance, and it's a linear measurement. It's just measuring between the upper first molars. And here is how it looks like in the mouth. Obviously, you are looking at my little typodont model and my Bowley gauge. And so you can see here, I've just placed it as if I would have done this on a patient. If we splay the little forks into the mouth, we can place them at the gum line, right here and right here. So now we have a distance between upper first molars of, if we look at the markets here, of 33. So we can see our typodont with an average size of 8.6 or 8.8 millimeter central incisor width, which comes in at a 33 measurement. And 33 millimeters across the palate between those two teeth is a very acceptable arch width. So now, in a perfect world, we're going to measure somewhere between 35 and 39. 33 is not a crime, but every now and then people walk in with 30, 28, 27, 25. Very narrow V-shaped arches, or even the omega-shaped because it squeezes upper first molars in a little more. And we're going to look at those in a few minutes. But what we do with the Bowley gauge is we measure it on every patient. And if you have studied models, you can just measure the model. Otherwise, these prongs are usually long enough, and the arms will extend right into the mouth. You can slide the gauge open and make the measurement between the two molars and just record it. Then you have an idea of what the patient's width is. Somewhere around 35. Is it 33 or is it something like 28, 29, 30? And that's a great way to start, establishing where in the mix of my information is arch width. Now, the third cause of crowding is improper torque of anterior teeth. An improper torque of anterior teeth is just a bunch of fancy words. That means that the roots are out of position. So you notice, the first two causes of crowding, improper arch form and improper arch width, deal with the arch in its entirety, meaning the anterior and the posterior teeth. The third cause of crowding restricts itself right to the anterior teeth, an improper torque of anterior teeth. In other words, when the roots are out of position, it's a cause of crowding. And so the quickest one to envision there is the Class 2 Division 2 patient. You can put that right into your head immediately. Class 2 Division 2. Upper centrals are reclined, upper laterals are proclined and usually mesial, kind of trapping the centrals, and the lower anterior teeth, lower canines, are typically elevated and also then very crowded. And so all of the roots of the anterior teeth are out of position for Class 2 Division 2 cases, and that's a leading cause of their crowding. The improper torque of the anterior teeth. So it's going to be a little less of a concern as far as our 4 secrets are concerned today, but it is the number 3 cause of crowding. Moving on to the 4th one, large teeth, and I will spend a minute on this just so we understand what the significance of large teeth is. When we're looking at small, average or large teeth, we have to remember we are talking about the width, not the length. The length of the tooth has nothing to do with the crowding. It's the width. How much room in its width does it occupy in the arch? Because we have a defined space from one side of the arch to the other. And we have to have all these teeth fitting in there with the mesial and distal contact appropriate so there is no crowding when we're done. Well, the width of upper teeth does have an effect. Certainly there are small, average and large teeth. So we will focus on the average first. We're going to establish the average width of an upper central incisor at 8.9 millimeters, and depending on what textbook you pick up, it's going to be somewhere between 8.6 and 8.9. So roughly a 9 millimeter central incisor is an average width. Now, there are 2 things to consider with the genetics here, real quick. The first is that we are looking at the upper central incisor width, only because the genetics do follow that. If your upper central incisor is wide, all of your teeth will be wide in scale. The only exception to that rule is when we have the peg laterals. So if you have a tooth size discrepancy with upper laterals being peg laterals, that can throw a little monkey wrench into it, but that's the only exception. So the genetics do hold true. If we have average central incisor width, we have average every single other tooth width. And the same goes for small or large. If we have small central incisor width, we have small every other tooth width. Now, there is a distinction when it comes to large, and that happens at about the 10 millimeter mark. When we measure the upper central incisor width, and it measures 10 millimeters or more, it becomes a significant part of why there's crowding. Because at 10 millimeters or greater, the teeth are going to occupy a lot of distance in an arch length. And there is the component of the genetics that sometimes is a problem for us. Because we want to move these teeth with Invisalign, we still need to have a foundation under them, and that means the alveolus. The alveolar housing is where these teeth are contained, and we don't just get to move them wherever we want, we absolutely have to consider the base that they're in. Well, the reason why large teeth become a more significant consideration in the cause of crowding is because of the genetics. The mismatch here is that just because a patient is given large teeth does not mean that they're given an excellent or big foundation to hold them in. So there is a disconnect in genetics there. When comparing the width of the teeth from tooth to tooth, the genetics hold. Remember we mentioned, if you have an average sized central incisor, all the other teeth will also be average sized. But if you have large incisors, for example 10 or 11 millimeter incisors, the genetics might not follow when it comes to the foundation that houses those teeth. And we know that view. We've seen it both ways. And imagine a patient that walks in and has tremendously wide teeth. So he has big teeth. 10, 11 millimeter centrals, they're all going to be large. And when they smile, we don't really see a lot of red or bleeding gum tissue, no plaque and bacteria. They have good habits. But they have a lot of buccal recession, almost from the centrals all the way back. It's because they were just not given the proper foundation to house teeth that big. The opposite is also true. We've all seen the patients with the small teeth. The cutoff there is about 8 millimeters, so when someone walks in that has less than 8 millimeters width of the upper central incisor, we have small teeth on our hands. And every now and then you see someone walking in giving you a big smile, and we have that 8 millimeter width of the upper central incisor. And then we have lots of spacing, because they have a tremendous or monstrous alveolar housing. So the genetic disconnect can happen there. It doesn't mean that if you get small teeth, you've got a small bone or alveolar housing to hold the teeth. Sometimes you get a big football player walking in, 6'4", monstrous kid, big smile, tiny little teeth, but a tremendous bone, lots of spaces. And so you can understand that just because you get small teeth doesn't mean that you get a small foundation. Just because you get large teeth doesn't mean that you get a large foundation. Now, it's more important to consider this for the large teeth, because that's where we get the opportunity to either help and control periodontal progress of the patient or to hurt it. So I love to measure the width of the upper central incisors because I like to know if I'm dealing with an average tooth. If I'm dealing with a 9 millimeter central incisor, fantastic. The good news is that's the majority of the population. In the bell curve of society, most people have the average. And then you have that percentage that has large teeth and the percentage that has small teeth. Since we see lots of people all day and all week and all year long, some of these do walk in. The key to the width of the upper central incisor is that once I see a 10 millimeter or 11 millimeter incisor, I immediately look at the buccal areas to see what kind of recession do I have there, if any. Do I have a nice thick bone or alveolar housing that these teeth are in? Because having these large teeth and it being a contributor to the crowding, obviously I'm looking to develop proper arch form and proper arch width to hold those teeth. Do I have the right foundation to move them into the arch? So I'm a big fan of measuring those centrals and making sure we're on track to have the right foundation to expand for a proper arch form and proper arch width to accommodate the tooth size that presents itself. Now, there are two things that are not causes of crowding, and we should cover them, because these two items here lead us down the path of treating symptoms versus treating causes. If we are looking at our photos and diagnosing our patients based on the four items I just gave you, improper arch form, improper arch width, improper torque of anterior teeth, and finally large teeth, when we're looking at these four items, then we are developing treatment plans that address the cause of the trouble. If we are looking at these next two items I'm going to show you, then we're looking at things that are symptoms of crowding. And treating the symptoms of crowding gives you a different outcome than treating the cause. So, here is the number one not a cause of crowding. Too many premolars. Too many premolars is not a cause of crowding. It may look like they don't fit. Fantastic, I know the picture, I've seen it. I know people who come in very crowded and it just looks like those four premolars will not fit. Well, we should take them out. But that depends. There are so many more things to look at. One way to look at the mouth is to see 12 teeth versus 14 in an arch, and can 12 fit? Well, that's one way to imagine it, and that's not really the correct way of doing it, because if you're heading down that road, what you're looking at is trying to treat symptoms. And having too many premolars is basically just not possible. We are supposed to have 8. We know what these cases look like. The more and more serial bicuspid extraction cases that you see, the more and more you realize that it really is just second best choice. Because of the patients who had 12 teeth due to bicuspid extractions, few and far between do you see having had a perfect orthodontic result and having had a nice occlusion set up and having had a nice aesthetic appealing smile. And all of the things that go into setting up a beautiful finish with Invisalign are really tough to do when you take out 4 premolars. So we are not in a hurry to extract teeth. And if we do so, we are really not treating the cause. And the next one. Too many lower incisors. Too many lower incisors is not a cause of crowding. That's a symptom of crowding. Yes, I know the patients that walk in. I see the photographs all the time. It just looks like 3 teeth fit. I can look at those photographs all day and all night, and you can show them to me and tell me that only 3 fit. And I agree. When you look at the lower 6 teeth, sometimes you see immediately that 3 fit. But the point is not to focus on the lower anterior teeth. It really doesn't matter how much crowding is there. You have to start to reverse your train of thought and take a close look to the upper arch. What kind of upper arch form do I have? What kind of upper arch width do I have? Do I have large teeth? Are they really wide? Because as soon as you establish, oh my goodness, this patient has improper arch form and improper arch width, then you start to change the shape and size of that maxillary arch, and the lower is going to follow it. And all of a sudden, you need those 4 incisors. So you don't want to start extracting a lower incisor just to make the other 3 fit in there. That's treating a symptom. And it's also addressing a tiny area of the mouth that's working in an area of 6 teeth. We are really looking into working in an area of 28 teeth. Because ultimately, when you are doing Invisalign, you have a number of goals in your mind for your patient. The first is obviously a beautifully appealing smile. Well, that comes from having all of the teeth in place, including the lower 4 incisors. And the second thing we are really looking for is a perfect occlusion, so that they can not only maintain their tooth structure, but also any restorations you might be doing, and their periodontal health for a lifetime. And the way you get the perfect occlusion is by having all of the teeth in a proper position, to keep them coming together in a fashion that is cooperative and not destructive. Now, secret number 4. Let's cover the buccolingual inclination. We can practice saying it fast 3 times on our own tonight when we have nothing better to do. But that's a handful. Buccolingual inclination. All right, let's define it. I'm going to read this a couple of times, just to be clear. I got this definition from the ABO, that's the American Board of Orthodontics, and that is the board that orthodontists go to and certify through. So when you're going to become board certified, they will examine cases that are presented and they're going to have criteria. Obviously, there are criteria that they look at. Well, buccolingual inclination happens to be one of them. So I'm going to read this, and then I'm going to put it in photographic view so you can understand it completely. The buccolingual inclination of the maxillary and mandibular posterior teeth. See, it says posterior. The buccolingual inclination of the maxillary and mandibular posterior teeth is assessed by using a flat surface that is extended between the occlusal surfaces of the right and left posterior teeth. There should not be a significant difference between the heights of the buccal and lingual cusps of the maxillary and mandibular premolars and molars, with all cusps within 1 mm of the straight edge. Okay? The buccolingual inclination of the maxillary and mandibular posterior teeth is assessed by using a flat surface that is extended between the occlusal surfaces of the right and left posterior teeth. There should not be a significant difference between the heights of the buccal and lingual cusps of the maxillary and mandibular premolars and molars, with all cusps within 1 mm of the straight edge. Let me show you what this looks like in a picture. Again, you get to see my typodont. What I've done here with the lower arch of my typodont, I laid a ruler right across the first molars. And by laying a ruler across the first molars and then taking a look from the anterior view, you could appreciate that definition. It means that you would like to have all cusps touching the ruler. In other words, when the posterior teeth are upright, the buccolingual inclination is: how are those teeth inclined? Are they inclined towards the tongue, towards the cheek, or are they vertical? When they are vertical, it sets up the cusps to touch that ruler. And if we have all of the cusps touching that ruler, well, then we're in great shape. The further these teeth lean towards the tongue, you can imagine only the buccal cusps will touch the ruler. And the lingual cusps will be farther and farther away from the ruler as the teeth lean towards the lingual. So now we know, as a part of board certification in the orthodontic world, they like those cusps to be on top of that ruler, touching that ruler within a degree of 1 mm. So you have a leeway of 1 mm. Well, that's not a lot. It means that those posterior teeth should be upright. If we lay it across the second molar, the same thing. Lay it across the second molars and take a picture. We would see that all those cusps come within 1 mm. And here it is from the lingual view. And so, if we have the lower teeth upright enough, we can see here we miss by 1 mm. Our typodont model measured 33. Remember the transverse measurement of the upper arch of our typodont model was 33? If it was 35, then the upper molars would be 1 mm wider on each side. And if this was 1 mm up on each side, we would be getting closer here. So, hopefully you can see the pieces of the puzzle starting to fit. A 35 mm transverse measurement typically comes with teeth that are vertically positioned or have very little buccolingual inclination, such that the buccal and lingual cusps all would touch a flat surface coming across the end. Well, what's the significance of that? The significance of having the proper buccolingual inclination has to do with occlusal forces and how that patient is going to do long term. It does have an aesthetic issue, because when the patient smiles, you can look into that buccal core. You don't want to see the black triangles, you want to see a full smile. That's part of buccolingual inclination. Getting the teeth out into position so that you can get the full smile. But the real reason why it's done is for the occlusal forces, because we know that there is a big difference between axial or vertical forces and lateral or horizontal forces. Lateral or horizontal forces are destructive and can cause trouble over time on all levels, tooth, gum and bone. But axial or vertical forces direct the force from the occlusal right through the bone via the root. And if we take a look at this next slide, I'll introduce you to my two uncles in the construction business. And I can say that. Don't get all offended. I'm Italian 100% through and through, and I do have uncles in the construction business. But this is Mario and Luigi, my two little buddies, to demonstrate what is proper and improper occlusal forces. Now, if you take a look at A, Mario over here does not have the proper ladder to get above the tooth and direct the force that would head down the root, so he's causing occlusal trauma to that tooth, because he presents and produces a horizontal or lateral force, and we know that's improper. Whereas Luigi has the proper ladder and gets to the right height, and if we have the teeth upright in the mouth, we have the best chance of those teeth landing and directing axial or vertical forces. So by establishing proper width and ensuring that we have buccolingual inclination taken care of, all of a sudden we deliver a better occlusion. Let's look at some cases real quick to show you what I mean in the real world. Because Beth walks in and has an issue with her smile. She is certainly concerned with the upper laterals. They look a bit off right there and she will want to correct that. But we have to look into the mouth to see what's going on. And when we look in there, we can see automatically, well, they're rotated. We have upper laterals rotated and we would like to correct them. We can see recession over here. This happens to be a 62-year-old female. So we would expect to see some amount of recession, and she certainly shows areas of it. But when we look at a case like this, we know right away from this photograph we won't really have proclining. That's an advantage. So with proclining out of the picture, we're down to expanding and also IPR. Those are two nice choices. As we move through the photos and we look at the upper arch, we certainly like to focus on this picture. It's my favourite picture. Looking into the upper arch gets me started. Remember, secret number 1 is the maxillary arch is the key. Now, if we look at this photograph, it's very easy at a glance to be hypnotized by those two teeth, the upper laterals. And what I mean by hypnotized is looking in there and saying, wow, there's just two teeth out of place, the upper laterals. They look like they need attention. That would be a little bit short-sighted because the reality is 14 teeth are out of place here. And if I want to get the upper laterals in proper position, I have to move 14 teeth to get them in. And if I'm going to address or treat causes of that crowding, I'm going to look at the improper arch form here. This is more of a V or a box with a V combined, because that arch comes straight up, straight across and straight back. A V-shaped, box-shaped combination, it is certainly not a perfect Roman arch that we would like to see right around. Now, one thing we would like to consider here is, imagine those laterals having erupted perfectly straight. Now, what would have happened to the canine? Interesting thought, right? If the upper laterals erupted perfectly straight into position, the canine would have erupted distal buccal to its current position. And so, if I want to get that lateral to where it belongs, I would have to draw the canine distal buccal. In order to draw the canine distal buccal, I can set up the posterior teeth to be wider. And by expanding the arch, driving the arch a little wider, we produce the room to draw the canine back to unravel the lateral. And so, when we measure the transverse dimension for Beth, if we measure the transverse dimension at 31 or 32, we know she's a little shy. And part of the reason why she is shy is because the teeth didn't come in perfectly straight. So, if I take someone who is 30 or 31, I know I can look for 4 millimeters of expansion here. And if I did 2 on each side, I would immediately look at the foundation past my mirror and say, wow, there is a pretty good amount of alveolar housing over here. If I can see the structure outside of the molars and premolars, I'm really in good shape to give myself a couple of millimeters of expansion on each side. And on top of that, we have great opportunity to do IPR, because we have restorations back here. So we could do wonderful IPR on some of these posterior restorations. Guide these teeth wider, draw that canine back and unravel the laterals. And that's one way to do it. The lower arch. We didn't even look at it yet, but now we can get a view of what's here. Oh, it's a pretty severe amount of crowding. It's the kind of picture we would look at and immediately say 3 incisor fit there. And there is nothing wrong with this statement, because if you look at these 6 teeth, certainly only 3 would fit. But we haven't given them their due diagnosis and treatment planning. Looking at what's going on back here, these are leaning in. These molars are leaning in so far you can read the whole buccal surface all the way to the recession. And that's not where the alveolar housing is. We could tip these teeth up, and as the anterior teeth expand, it gives you room back because you upright or expand those lower teeth. Number 1. You get more arch length all the way around to fit these teeth in. Number 2. You improve the buccolingual inclination. Now, these are crowns back here, but it's no surprise that teeth are leaning in towards the tongue over the course of a lifetime, have had fillings, then root canals, then crowns, and they're going through the whole spectrum of dentistry. Most likely, a component of that is their occlusion. And this patient does not have a proper occlusion set up in the posterior when the teeth are leaning that far in. So now we take a look at the full diagnosis, and we know that the upper arch allows us to do some expansion in the posterior. Then we can work on our buccolingual inclination of those lower posteriors, uprighting those teeth, which should open up some room to get these lower anteriors in place. So let's take a look at her right side. Most of the population, I think, is somewhere around 60% have class 1. So, you're going to have that class 1 canine and molar in 60% of the population. And that's good news, because then you look at your class 2s, and that's a significant portion of the remainder, maybe 30%, 35%, and class 3 might be 5% of the population, something like that right now. So, you're in luck when you see your class 1 canine and molar, because you have no AP corrections to make for a case like this. So, we take a look at the ClinCheck page, and it will show us different views. But I like to focus in on the maxillary arch, because I know I wanted to bump it out a little bit. I know there is IPR in the case because I put it in there. I put it behind the canine. And canine premolar IPR is wonderful for establishing width and for going to expand. I love to put IPR on the posterior teeth. So, for upper laterals like this, I like to see them treated well. I try not to IPR them. I find that doing IPR in the anterior, the cutting and spinning technique, so to speak, doesn't work very well, and those teeth don't track nicely. But if we are expanding and creating the room, and then bringing the teeth into place without doing IPR in those areas, I find it tracks better. Let's press play and we'll look at that upper arch, and we will see a little molar and premolar expansion. The canines will draw back to their position and upper laterals will be placed. And now we have a wider arch, so now we have established a proper arch width. We now have a better arch form. Now we have that Roman arch we were looking for, following those cusps and incisal edges all the way around. So, as we play that view, we can see how that canine was brought into position and the lateral was then brought into position. And if this was a patient who walked in without any crowding, that's where the canine would be. But since the patient didn't walk in that way, upper laterals are rotated. The canine is mesial to where it should be. So we want to set all 14 teeth where they belong, and that's how upper laterals go into place beautifully. Now, in the lower arch, obviously the lower teeth need to be expanded or uprighted, as we call it, to establish proper buccolingual inclination. And doing that gives us room for these teeth. Now, the IPR count in the lower arch was 1.5 millimeters. I did 0.5, 0.5 and 0.5. I started at the canine, number 22, and there was 0.5 here and 0.5 between the two premolars, and 0.5 between 19 and 20. And 1.5 was the total IPR count for the lower arch to unravel of what could be, if you're looking at the 6 teeth, maybe 5 millimeters of crowding, something like that. So, with a very small amount of IPR, we can unravel some very nice crowding in the lower arch and keep all of the teeth. And obviously we should have nice overbite, overjet, canine guidance at the end of the case. And by having all of these teeth placed appropriately, the uprighting allows us to have better occlusal forces on the posterior teeth. So, when we take a look at the final photos, we can recognize the arch is a little bit wider, about 3 or 4 millimeters. The alveolar housing is still out there, We haven't caused any harm. By going wider, we still have a nice foundation out there. We can follow the cusps and the incisal edges all the way around. In this case was treated without attachments on upper laterals. So that technique for me, without attachments there, has developed very nicely. By establishing the proper arch form and the proper arch width in the upper arch, it allows the lower arch to follow it. As we upright those teeth that were leaning in completely towards the tongue when the buccolingual inclination is taken care of and they are upright, all of a sudden there is a lot more room. Because the arch form is different, the arch length is different, the arch width is different. And so all of a sudden we can keep those 4 incisors. Here is the lingual bar in place. I'm a big fan of the lingual bar, by the way, so I like to keep all 4 incisors and have the patient have a nice occlusion at the end of the case, with teeth that are upright, proper arch form, proper arch width, and in the end we get the smile. It's almost incidental that the smile will occur, because as you develop width, you fill in the sides. A little bit of bleach gel goes a long way, and so I recognize this photo is a bit darker. The teeth were not that brown to begin with. The whole photo is a bit darker, but a little bit of bleaching and Invisalign goes a long way. You are looking at teeth that are unrestored. It's her own enamel. There are no veneers and or crowns across there. But having established a nice pattern of developing and treating arch form and arch width, we can align all those teeth and maintain a nice midline. And having all 4 teeth in place gives the patient a midline and also a beautiful smile. Now, let's meet Robert. Robert is walking around scaring all the kids in the neighborhood. So Robert can't go out in public like this. We're aware of that. But Robert is a young and healthy and educated and willing participant when he's educated about the benefits of Invisalign. A question, just to keep in the back of your head, is why would Robert be walking around with a smile like that? And you would be amazed how many of your patients are walking around like this, because they've been told that they are not candidates for Invisalign. And it usually comes in a package of 3 items, they've been told. Number 1, they need 2 years in braces. Number 2, they might need extractions. Number 3, they are not a candidate for Invisalign. Invisalign can't accomplish the goals that should be done for them. And so the more you talk to your patients, the more you educate them, the more you recognize they are very willing to do Invisalign. The dynamic is such that patients like this, a 38-year-old male, will choose to keep that smile that he can't stand for the rest of his life versus doing braces even for 1.5 years or 2 years. Now that's a powerful choice, right? This patient knows he could have had braces. He has been to consultations. But to choose braces for 1.5 years is unappealing. So they will stay with a smile they don't like forever versus putting up with braces for 1.5 years. That allows plenty of opportunity for Invisalign treatment. Let's take a look at Robert. When we look into the mouth, we can see buccolingual inclination from the anterior view. When you see the posterior segment leaning in this far, you have a poor occlusion. This is a dramatic occlusion because the teeth are leaning in so far. You could not possibly have them upright enough that the buccolingual cusps will touch a ruler laid across the flat part of those molars. And so by looking at an occlusion like this, you know that this arch is way too narrow. You have improper arch form and improper arch width without even looking at the individual arches yet. So clearly, what you're looking at here is an omega-shaped arch. So let's take a look at it. The omega-shaped arch is characterized by upper second molars being placed much more to the buccal and almost in perfect position. They almost always occupy the right spot. But the first molars come in, and they come in heavy. So upper first molars are placed obviously to the lingual. And it sets up a perfect space here to measure a transverse measurement. And Robert, if we were to place our Bowley gauge in here and measure it, and we did, he measures 25 millimeters between these 2 teeth. So I have 25 millimeters to work with between these 2 teeth. And we can see that perfect omega shape where we can follow the cusps and curve into the canine. So we have this indentation, this curve here, and then we wrap around here and we come back this way. Now, looking past the teeth, and it's always important to look past the teeth, you notice out here there is a line. Well, that line delineates the shape of his alveolar housing. The alveolus, the maxillary bone that is holding those teeth, interestingly enough, does not have an omega shape. It has a dome shape. Look at that. Surprise, surprise. Most times, the alveolar housing doesn't follow the omega shape of the teeth. Your alveolar housing will probably be a dome shape. And so, we know now the foundation is already laid in the right place, and we have to move the teeth to follow it. There is a lot of bone out here to move those teeth, to set them where they belong. So now we know we are starting out very narrow, improper arch width. Absolutely, improper arch form. Absolutely. We have a classic omega shape here. I see where upper laterals are, and I'm not worried about them. We're going to get them into position, without IPR on those anterior teeth. This is another case where I provided posterior IPR to establish the position of all these teeth. And with a lot of expansion and a little bit of posterior IPR, we can have upper laterals flow to position, without attachment. Well, obviously with an upper arch looking like that, the lower arch is going to have an amount of crowding. And there is a significant amount of crowding here, but never mind the anterior teeth. Back to the posterior teeth. They are leaning in. We can see the entire buccal surface all the way down. We knew from the anterior view that these teeth were angled in, and there is no way the lingual cusps are on the same level as the buccal ones. So we have to keep in mind buccolingual inclination and look to upright this. And the alveolar housing is such that it's in a shape of a nice Roman arch. We love to establish a dome for these teeth. The right side. We have class 1. So again, with a nice class 1 canine and molar, this should be a pretty straightforward case. We're looking at very healthy bone here. We know from the occlusal view that we have a nice thickness of alveolar housing here to move these teeth into, upper and lower. So a crossbite over here in one molar, not too much of a concern. Those of you providing Invisalign know that correcting a single tooth crossbite is very predictable and should not offer any complication to the case. Let's take a look at the ClinCheck. My favourite view is obviously the upper arch, and that upper arch has that beautiful omega shape which we want to get rid of. And the way to get rid of that is with Invisalign. That would be the choice of treatment for this arch every day of the week, to get Invisalign aligners in there to do this. Expand and provide proper arch form and proper arch width. Now we have a beautiful Roman arch. So we've taken the omega shape arch and created a beautiful Roman arch. And now you're ready for the lower to follow it and have all those teeth fit in with the minimal amount of IPR. And this case had about 2 millimeters of IPR in each arch, but in the posterior. I keep it in the canine and premolar areas. I'm just happier to do posterior IPR than anterior. So I like expanding, and when this patient measured 25 millimeters to start, we ended up doing 7 millimeters of expansion between upper first molars. The final width across here is now 32, so we went from 25 to 32, and the reason why we are at 32 is because we added a couple of millimeters of IPR, and he does have average-sized teeth. These are about 8.8 millimeters central incisors, so with the 32 transverse measurement, having had some IPR, he has the right arch width and the right arch form. And upper laterals flow to position beautifully. Now this case was 20 aligners. We used 20 aligners, and then I used 8 for refinement to make it perfect. And we finished him here. When you look into the posterior segment, you can see the buccolingual inclination. You can see what I mean now. They are upright. And when they're upright, we don't have the interferences that we have over here. Because all of the inclines on these posterior teeth hit, and that produces interferences, lateral or horizontal forces, and really an occlusal design that is going to destroy those teeth and those fillings and that gum and bone eventually. Whereas this is much healthier and a proper occlusion, even by the best of orthodontic standards. What does the arch look like? Well, it looks like this. When we were finished with 28 aligners, which is a 14 months time frame, we have 32 millimeters between these teeth now. And so we have proper alignment of all these teeth, and upper laterals go to position beautifully, and a little bleach gel goes a long way. Takes all the colour off there. The lower arch will follow. If we have done 28 aligners and spent 14 months shaping that upper arch and developing proper arch form and proper arch width, the lower teeth are going to upright. And the difference between before and after is huge, because this is a posterior segment that is set up to receive proper vertical occlusal forces. Because the buccolingual inclination on the lower is perfect. And on the upper arch too. And when you set that up properly, you can have nothing but improvement in your posterior occlusion. So, we don't want to get too focused on this when we could drive all of those teeth into proper placement, not only enhancing the aesthetic result, but producing a proper occlusal setup for your patient to go through with vertical or axial forces on those teeth. And then, as an end result, almost incidentally, you're going to get a nice smile, because aligning, leveling, derotating, providing expansion, filling in that buccal quarter, uprighting those posterior teeth, all those things we've been doing to establish the final position of the teeth make for a nicer smile. So, in the end, we could let Robert back into the public. Obviously, he won't be scaring any kids anymore in the neighbourhood. Now, Laura. A little different case. She's not so happy, and you can see that here. She's not so happy for a good reason. She's about 62 years old, and she's unhappy with her smile. And she would describe it as bug teeth or Bugs Bunny. You know, the front teeth are sticking out. She had nothing to show for the rest of her mouth, so her smile is compromised. And she even pulls her lip up there to hide what doesn't show there, so it's really not a natural smile to begin with. And when we look in the mouth, we can see and determine that these are average-sized teeth. I can tell you that these are 9mm centrals, so they're not big. Just because they're prominent in the smile doesn't mean that they're wide or large teeth. So the first thing I did when I saw that smile is measure to determine, well, we have an average width of tooth, so there must be something else going on here. And the right side gives me that Class 1 setup. We have canine and molar in Class 1 on both sides. So, having a Class 1 occlusion is always much nicer and easier to work with. But the upper arch shows me the big problem. And when we are focusing in on the entire arch, and remember the maxillary arch is the key, we can see here that's improper arch form. And so, if we're looking at improper arch form, we would take a look at how that's more of a letter V. That's a very common diagnosis to have a V-shaped arch to be protrusive. Those go hand in hand. Typically, a V-shaped arch is a little protrusive. Well, if we're going to develop the arch width here, we can retract the centrals a little bit, and that would set us up for success. And we can see here the amount of crowding that's associated with having the improper arch form. And when you look at the posterior teeth more closely, you see how they're leaning in towards the tongue. They are leaning in so far that all we can see is the entire buccal surface, all the way down, including the concavity here. So that's an amazing lean that these teeth have. They need to be upright. And we can upright those teeth, and by doing so, improve the occlusal forces on the posterior segment. So when we look at the ClinCheck, we'd love to see that upper arch develop into a proper arch form. And that would allow the lower teeth to be uprighted, so the teeth that were once leaning in stand tall and straight, improving that buccolingual inclination. And that sets us up for great success to get that patient from here to there. Now let's get to the upper arch and take a look at the difference. This is what we mean. Getting that V-shaped arch to a nice Roman arch. So we went from Gothic to Roman, using Invisalign. And the patient let me change a filling too. Obviously that became a nice saw after the arch was shaped. So once we have the teeth in position like this, the lower should follow. And there is a big difference in how posteriors are upright versus leaning in over here. So, from leaning in completely, poor buccolingual inclination, to appropriate buccolingual inclination. The uprighting of the posterior teeth allows for the room to unravel that crowding. So, we did have 4 millimeters of IPR in this arch, and there is a lot of crowding here. And to go through the exercise, we could say, well, there is probably 3 millimeters here, 4, 5, 6, 7, 8, 9, maybe 10. It almost gets a 10 millimeter of crowding. We did 4 millimeters of IPR. But the trade-off there is that 4 millimeters of IPR versus an extraction, premolars and or incisors. So the 4 millimeters of IPR becomes an advantage in the case because we don't have to lose good, healthy teeth. And if we take a look at Laura before and after, we can see, well, that she now has a more appealing smile. She would pull those lips back and show you all those teeth because now they actually fill in her smile. And here I actually have the 4-year follow-up. So 4 years later, we have a set of photographs showing you a perfectly healthy foundation. Very nice buccolingual inclination. Those teeth are upright. So they come together with proper occlusal forces on the back teeth. And when we look at her class 1, it still exists. On both sides. And our arch form holds the position because the occlusion is set up properly. It is not going to sink back in. So we are going to have that perfect arch form maintain itself. And over time, even the posterior molars, which were completely leaning in before we started uprighting them, are still upright. And that allows you to set up a nice arch form and unravel very good amounts of crowding and address everything, including the posterior teeth. So, we are keeping track of those keys to success, right? The secrets. The maxillary arch is the key. The transverse measurement is important. Make sure you look really into what caused the crowding. Is it improper arch form? Improper arch width? Those are the 2 things to keep track of, and buccolingual inclination. The last case I want to share with you is Olivia, a 17-year-old girl. Now, in my experience, it's very difficult to get a 17-year-old girl in braces. That's senior year high school. And senior year of high school has its own issues and things to deal with, but to wear braces as a senior in high school, number one, they would be a rarity. There wouldn't be many students with braces, and it would probably be a source of trouble for a teenage girl to have braces on, so she refused orthodontic care. Now, let's get to the case. Okay, so we have class 1, so we're in great shape. Canines and molars in class 1, healthy gum and bone. Looking good. When we look at the anterior photograph, we can start to see what's happening. Certainly, we recognize that those canines are out of position. There is no canine guidance happening over here. There is a big gap between this canine and that canine. We can count 3 incisors, but we don't see the 4th just yet. So, we are not perfectly level or aligned or derotated. But we have to explore a little further to find out where the problem is. I can see the photograph is a little blurry over here. I apologize, I obviously took that photo. This arch form is not correct, and if we had a perfect arch form here, that would go a long way to helping us with what's happening here. And the reason I am showing this case is because if I take a look at my 4 keys, my 4 secrets, they all apply to this case. And they all apply in such a way that there is no IPR to treat this case. And Olivia is one of my most recent, let's say, finishes with that. So, in the past 5 years of providing Invisalign, I certainly have evolved in how I tackle my cases and how I treat them. And Olivia, from the moment I saw her, I knew there was not going to be any IPR in the mouth, and I was not going to take out a tooth. We are going to keep this tooth because there is too much going on here. There is teeth leaning in completely, and they are totally derotated. The width is narrow, both upper and lower, and the arch form is wrong. So we have improper arch form, improper arch width. We need the buccolingual inclination addressed, and the good news is we don't have large teeth, so we should be in good shape. If we watch the ClinCheck play, we can see how the upper arch is going to take proper form. Predominantly, premolars are being expanded. Upper molars are not that far out of position. So, we're going to have mostly a premolar change for getting that arch form developed. But without any IPR, we can establish a beautiful arch form around the upper arch, which means that the lower is going to follow it. And so when the lower follows it, that means that this lower incisor should be able to go into position as the arch is being developed. So, if we applied all those secrets that I gave you to Olivia, it becomes a very routine case, not a complicated case. It is aligner-only therapy, and now I'm going to show you the result at 11 aligners. The reason why that it's up there is because that is the final upper aligner. We just needed 11 to make that arch form perfect. This happens to be the photograph I used at the beginning of the presentation to show you what good arch form is. This is good arch form. And once we develop good arch form, we know the lower teeth, when the buccolingual inclination is correct, will have to follow them. But let's take a look at the process. Here's aligner number 12. So, with aligner number 12, we're halfway through treatment. It's obviously going to show the plaque and tartar buildup. We always had to clean that tooth up, and it was hard for her to maintain. She is opening here for me. That's not her occlusion. I just wanted her to open to show that tooth on a picture. Lots of attachments, driving these teeth to become upright and derotated. And we have to unravel all of these premolars and derotate everything and establish proper buccolingual inclination of all of these posterior teeth to have all of this fall into place. Aligner number 20. Here is the 10 months mark. At 10 months, the premolars are starting to stand tall. And now we have teeth that are derotated and we have room for tooth number 23 to start taking its position. And here is the aligner number 20 showing the fit. It's a little bit off, but we're not too concerned. You know, we're bringing this tooth from a very poor position to an excellent position, and we always have refinement to do a little bit more work if we like. And aligner 23. We're approaching the 1 year mark. And we can see at the 1 year mark we're developing our arch form and our arch width, and our buccolingual inclination is starting to shape up. These teeth are no longer leaning in, and the space for that tooth is now evolving into a perfect spot to park it in. When we get to 27, it's the first round. 27 was the count of aligners for the lower, 11 on top, 27 on the bottom. And this tooth is now here, so we've come a long way with our positioning of all those teeth. But we need a little refinement. So at this point we do some refinement to finish the job, because this incisor needs to come a little bit more, and that root has to follow under it to have that perfectly placed. But you can appreciate the amount of premolar movement, because these teeth were turned and leaning in, and they are now upright and derotated. And the same thing on the posteriors. How far these teeth were leaning in versus how they are standing tall now. And so, as we upright these posterior teeth, the final set of photos looks like this. We know the upper arch was completed at aligner number 11, but the lower arch looks like this. And so to have that arch form established on the top, arch form and arch width, it then allows you to develop the buccolingual inclination of the posterior teeth and establish a proper arch form and width on the lower, and all of a sudden, the tooth that really looks like an extraction over here can look like this over there, with no IPR in this case. Right side class 1. This needs a little time to settle, and as you're wearing retainers like Vivera overnight, it gives us a chance to settle. And as it does, we would change the retainer once it's in a better place. Here again, class 1 occlusion. We've established the canine and molar position, and everything is lined up very nicely, no interferences. And as the patient bites down, we have level, aligned and derotated the entire case. And when we look in there, we have upright posterior segments, not leaning in, causing interferences and poor occlusion. So, as we establish the width and the arch form, we also establish the canine guidance. And if you look at the left picture here, you can identify that the canines are not in the position for guidance. And yet, over here on the right picture, they are. And so, by establishing all of the things we talked about, recognizing that the maxillary arch form has to be addressed, recognizing that width has to be accurate, and recognizing that the buccolingual inclination of those posterior teeth has to be appropriate, it starts setting up a position where you can have overbite, overjet, canine guidance, and not to mention keeping all of the teeth. And now we have 4 incisors sitting there, and that makes for a very happy Olivia, because here you have a teenager that went through the senior year of high school wearing Invisalign versus wearing braces. A little bit of bleach gel goes a long way for teeth that were not too dark to begin with. And now she is a college student in DC, doing very well and loving her smile. So, in summary, focus on the maxillary arch. Pay attention to the upper arch. Look for the arch form. Look for the arch width. And pay attention to the posterior teeth. Arch form and arch width are huge. Those are your 2 big causes of crowding. If you're looking at the arch form and arch width, that really allows you to open up your world to unravel more significant amounts of crowding with less or no IPR, especially on younger and healthier patients. And by identifying what caused the crowding, it gives you an opportunity to treat the causes of the crowding, and not the symptoms of the crowding. The transverse measurement. For many of you, that might be a new dimension. You certainly can pull out orthodontic textbooks and look it up. It's the distance between upper first molars and gives you an idea, or at least a range, of where is my patient versus where they should be. And to have somewhere around 35 millimeters would be appropriate. And so when you start measuring the transverse measurement and you see a patient that's 31, 29, 28, or in Robert's case 25, you know you have some room to expand. And so now you have to look at the size of the teeth, the health of the periodontal structures, and start to determine, okay, where is my arch form? Where is my arch width? How about that buccolingual inclination? And the more and more I addressed the posterior teeth and I uprighted them, the more I saw there was no need for occlusal adjustments at the end of the cases. Because when you have that buccolingual inclination established, you have the right occlusion. So, almost always you're going to be expanding or uprighting those posterior teeth into a better occlusal scheme, not a worse occlusal scheme. And for me, I'm wrapping it up now, so just to say thank you, you were a wonderful audience.